the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
A very good afternoon to one and all. I am Dr. Farheen Patel, Assistant Professor, Community Physiotherapy from Sancheti College of Physiotherapy. And I give you a very warm welcome for our 10th talk, which is Osteoporosis, Incapacitating Indian Women. Our chairperson for today is Dr. Anu Arora ma'am. She is professor in D.Y. Patil University School of Physiotherapy. She is the gold medalist in her master's and has numerous publications in her national and international journals. She is a certified birth educator. She has conducted various health promotion and ergonomic lectures and workshops for various populations. Author, and she is also author for chapters in physical rehabilitation, and she's currently working on a book on women's health. It's a pleasure and honor to have you, ma'am. And our speaker of the day, and it's my immense pleasure to welcome Dr. Surgeries ma'am. She is a professor and HOD at Sancheti Institute College of Physiotherapy. She is a PhD scholar in D.Y. Patil University, Navi Mumbai. Her PhD study is on pelvic health among adolescents. She is a certified ANC physiotherapist and has keen interest in women's health promotion. She has various publications in national and international journals. A very warm welcome to both of you, ma'ams. I would like now to hand over the session to Surgeries ma'am.
Thank you so much, Dr. Farheen, for the kind introduction. And before I begin the session, I would like to thank our organizing chairperson and principal sir, Dr. Apurva Shimpi, to allow us to have this wonderful webinar at first place, and also give me an opportunity to be a part as a speaker for one of the sessions. And side by side, I would also like to thank Dr. Anu ma'am, who also happens to be my guide. So I think it's a privilege to share this platform with her on this such a beautiful topic, which is osteoporosis. Thank you so much, ma'am. And with this, I would like to begin my session. Is my screen visible?
Just a moment, ma'am. Yes, ma'am, we are able to see.
Yes.
If you could put it in slideshow, ma'am.
It is in slideshow?
Right, ma'am. Yes, ma'am.
So osteoporosis in capacitating Indian women is the topic for this session. So the objectives of this session are, I will be discussing the definition and types of osteoporosis, diagnostic criteria of osteoporosis, clinical features of osteoporosis, menopause, the link between menopause and osteoporosis, and if there is any relation between osteoporosis and pelvic health. And finally, I'll end with contextual factors. And from thereafter, Aru ma'am is going to take over the session. So before I begin this session, I would like to discuss the definition. So as we all know that osteoporosis is characterized by the presence of both low bone mass and a disruption of normal bone architecture, which results in loss of bone strength. So what happens in osteoporosis, we all know that the normal bone architecture becomes compromised because of many factors. It could be primary factors, it could be secondary factors, and finally, because of which the bone mass is compromised, and we conclude by saying that there is loss of bone strength. And WHO also defines osteoporosis as a bone density measure which is more than 2.5 standard deviation below the mean of young healthy adults of similar race and gender. This is something we have to always remember, that when we are classifying or when we are diagnosing somebody with osteoporosis, the comparison of the bone mineral density is always being done with the same race and the same gender. So before I move on to my next slide, I have a quick question for the audience. You all can answer over the chat box. Which are the 3 hormones responsible for calcium metabolism? Which are the 3 hormones responsible for calcium metabolism?
One of the answers is estrogen, ma'am.
Yes. Quick, you just have 1 minute. 3 hormones. Okay, so I guess I'll give you the answer. So the first hormone which is responsible for calcium metabolism is the parathyroid hormone. The second one is the calcitonin, and the third one is the calcitriol, which is also known as 1,2,5-dihydroxyvitamin D. So coming to the statistics of osteoporosis, so this is basically the need, or why is it so important for us physios to know about it, to talk about it, to discuss about it. So if you see that the prevalence of osteoporosis is said to be, it is going to rise by 2050. So much so that it is going to kind of affect both the genders, and global osteoporosis sufferers are going to be around 6 million in around the world. And out of which, if you look at the statistics, what they say is 3/4 of it will be from the developing countries. And as you all know that one of them is, of course, India. So why is it so important? Because the global burden, the global health threat due to osteoporosis is ultimately are the osteoporotic fractures, which primarily happens in the spinal areas, the spinal fractures which we are talking about. So as you all know, it's part of the axial skeleton. So why it is so much important to know that how osteoporosis becomes a threat to the health, for the health. Secondly, after spine, the joint which is going to be the bone which is going to be at risk is hip, which is the major part of it is the cancellous bone, the wrist joint, the wrist, and of course there are sometimes fractures around humerus and ribs. So before we move on to the next slide, I just want to know that what are the common risk factors for osteoporosis? So those of who you want to answer can answer over the chat box. The common risk factors for osteoporosis. I think one of them I've already mentioned, the developing countries. So I believe Asians and Caucasians.
Few answers say age, postmenopausal women.
Yes, staying near equator.
Staying near equator, obesity.
Okay, perfect. I think we have got all the answers. So yes, first and foremost, it is always going to be the gender. followed by the race, gender, of course, because females are always more, they are by gender at risk, especially postmenopausal. Race, the Asians and the Caucasians are supposed to have small bones. So because of which they are by default at risk of getting osteoporosis. Family history. Now, this is something very important. If somebody in the family has a history of osteoporosis, then automatically the family members becomes, that is the subsequent generations, they become kind of 70 to 80% at risk, more risk as compared to others to be prone to osteoporosis. And age, yes. So we all know that after 45, after 50, for every 1 year, there is 5% bone loss, which can happen physiologically. So of course, age is a very important risk factor. Lifestyle, and of course, certain medical conditions like your hyperthyroidism, hyperparathyroidism, and Cushing syndrome. So now coming to the types of osteoporosis. So the bone loss which happens, it can happen due to normal aging. It can happen due to the hormone alteration with respect to estrogen due to menopause, or sometimes when the cause cannot be found out, it will be mentioned as idiopathic. So whenever the bone loss happens due to normal aging or due to hormone alterations due to menopause or idiopathic, we tag it as primary menopause. And whenever this bone loss happens due to endocrine dysfunction, I just mentioned about few like hyperthyroidism, hyperparathyroidism, or Cushing syndrome, or any other endocrine neoplasias related to bone. So automatically the bone architecture gets compromised, the bone mass gets compromised. And therefore, again, these people can be diagnosed as secondary osteoporosis. GI dysfunction, it is so important because we all know that the calcium absorption happens from the intestines. So anything with respect to the small, the large intestine, colon, anywhere in the pathway. So sometimes even irritable bowel syndrome can result in secondary osteoporosis. So, and of course, as a side effect to certain drugs like corticosteroids, some of them can be phenytoin, prednisone. So long-term effects of corticosteroids also causes calcium loss as a side effect. Therefore, a secondary osteoporosis can happen. And finally, as physios, we all know that after any of sort of fracture, any sort of immobilization given as a treatment to any patient, can cause to secondary osteoporosis if it is prolonged. When the healing takes a lot of time, sometimes the immobilization gets prolonged. So obviously the main important stimulus to the bones, which is the forces, the weight bearing forces, which are grossly minimized and therefore can lead to secondary osteoporosis. So before we move on to our next slide, that is diagnostic criteria, I'm very sure everybody in the audience knows about the T-score and knows that any given point of time, if you're asked that, okay, what is the diagnostic medium or criteria for osteoporosis, you'll quickly answer T-score. So if anybody is aware about how this T-score is derived, I'm not asking about the gradation of T-score. I have that in my next slide. So all I'm trying to ask you is, how is this T-score derived? What is this T-score? How is it derived? Yes, it is done through, we get it through DEXA scan, of course, but what is this T-score? Okay, so the T-score is basically when we compare, it is basically derived by comparing an average score of a healthy 30-year-old of same sex and same race. So for example, if I am 34-year-old female and I go for my bone mineral density examination, and there is the result which is found after the examination, it is compared with a 34-year-old female of the same race, and then that T-score is derived. And therefore, there is something missing in this particular slide. If you see, the scores are fine. The information is right that T-score more than -1 is normal. T-score between -1 and 2.5 is osteopenia. T-score less than -2.5 is osteoporosis. T-score less than -2.5 plus there is history of fragility of fractures, is severe or established osteoporosis. But something which is so important is the difference, that is the T-score. What I said is that it is the difference between the normal young and the patient score. Therefore, the term SD, standard deviation, needs to be mentioned because it is not going to be same for every gender, every age, and every race. So therefore, whenever you mention the T-score, you have to mention that, for example, for normal, T-score is more than -1 standard deviation. T-score for osteoporosis is less than -2.5 SD. So now coming on to the clinical features of osteoporosis, normally it goes unnoticed because for some reason, due to lack of awareness, you can say, or due to lack of say laziness, sometimes it's due to economic reasons, people do not get themselves assessed in the perimenopausal period with respect to their bone mineral density. So most of the time it goes unnoticed. And when a patient comes to you with back pain, on assessment, your orthopedic, or you find out that there is a component of fracture or a collapsed vertebra, and that's when it's commonly diagnosed. And you also, the one of the clinical features is also that there is loss of height over time, because the bone architecture in itself starts getting compromised. So there is a loss of height over time. That is again a very, very classical clinical feature. You see a stooped posture in your patient, and of course, bone that breaks easily and repeatedly than expected. So even with trivial forces, there is a fracture. So of course, that is something which is a classical clinical feature of osteoporosis. Now, what is the relation? We all know that estrogen is kind of the link between menopause and osteoporosis. But how exactly this concept has come into the picture? So there is something called as the peak bone mass. Now, peak bone mass is the maximal bone mass a person can attain or obtain in his entire lifespan. So they say that for females, the peak bone mass is somewhere around in the early 30s, and in males, it is somewhere around in the late 30s. So how this peak bone mass is associated with with osteoporosis is, there are many genetic factors, which I'll show you in my last slide, that there are certain genetic factors in all of us which determines the peak bone mass. And side by side, the hormonal status of estrogen also regulates this bone mass activity in the entire lifetime. So because of that, because of this regulation, which estrogen does with respect to the peak bone mass one obtains, so therefore, after the estrogen decline takes place post-menopause, this becomes compromised. Now, along with it, there are certain other factors which also determines or regulates this peak bone mass. That is the nutrition, any addictions, or your physical activity level. Therefore, it becomes so important that not just during perimenopausal age or during the menopause that you must make your people or your population aware about post-menopausal effects or weight-bearing activities or osteoporosis, because this peak bone mass is something which is determined over your entire lifespan, starting to be right from your beginning. So therefore, these factors, right from nutrition, addiction, and exercise, of course, good nutrition, good exercise, and low addiction are the important factors to determine peak bone mass. Therefore, this has to be sensitized to our population right from the beginning, and not just during the perimenopausal or the postmenopausal age group. And as we all know, we have learned in our pathology that continuous remodeling, osteoblastic and osteoclastic activity, osteoclastic is the bone, the one which osteoblast is the one which forms the bone, and therefore this continuous remodeling also gets affected because of estrogen deficiency, and therefore we do see osteoporosis in this population specifically. Now, there are some studies which are done on postmenopausal women where they have found that postmenopausal women are diagnosed with osteopenia, and those who were diagnosed with osteopenia whereas they were at risk for fecal incontinence but not urinary incontinence as compared to normal women. So this, how they kind of justified this is there is modulation of collagen and other connective tissue remodeling is sometimes associated with estrogen and selective estrogen receptor modulators. And that's how they have kind of come to the conclusion that somewhere the anal hiatus, the collagen around the anal hiatus could be affected, and therefore fecal incontinence could be, they are more at risk for fecal incontinence than urinary incontinence. But as I said, that there are hardly any studies on this, so we cannot really take we have to take this evidence with caution. So how exactly estrogen they came up with estrogen as management for postmenopausal osteoporosis. So right in 1940, so basically this is just for your general knowledge, right in 1940, Albright and Reinfenstein found that estrogen could prevent osteoporosis, but there were subsequent studies going on where after that in 1960, they found that there is an association between menopause and osteoporosis, and they first identified that estrogen treatment could be adopted to prevent bone loss. And after that, North American and Chinese Menopause Society guidelines currently only recommends hormone replacement therapy for women at risk for fractures only due to the side effects. So we all know that there are certain cardiovascular side effects with respect to hormone replacement therapy. Therefore, only those who are at risk for recurrent fractures due to osteoporosis should be advised hormone replacement therapy. Now, this is something interesting, therefore, I thought to share with all of you. But as I said, that these are a couple of evidence which have to be taken with caution, and there are more histological research updates to be needed. So like I discussed about fecal incontinence being common than urinary incontinence in certain studies with respect to osteoporosis. So there are a few studies which have said that pelvic floor disorders, including pelvic organ prolapse, urinary and anal incontinence, are hypothesized to have combined manifestation with low bone mineral density, indicating generalized disturbance in collagen metabolism. So how the studies which kind of are trying to say that there could be a relation between pelvic health and osteoporosis, the justification they are giving is the normal collagen metabolism, estrogen being part of it, or estrogen receptors being involved in it, because they get compromised. Therefore, the pelvic health or pelvic floor disorders may take place in people who already have diagnosed osteoporosis. Also, a couple of studies say that women with osteopenia had increased risk of incontinence and solid stool. Now, as I discussed in my previous slides, that GI issues sometimes, a lot of times, can cause calcium metabolism affection. So therefore, so we are not really sure about the cause and effect, but all they could find that there was a correlation. There could be a correlation between osteopenia and risk of incontinence and solid stool. So it could be so that if there are any GI issues in people, it could further lead to calcium metabolism affection and further lead to osteopenia. And lastly, also there are studies, there is a study which says that pelvic floor disorder may be linked to lower bone strength through common pathophysiological pathways of connective tissue deficiency or metabolism, but it still reflects contradictory evidence. So therefore, there is still scope for research in this field, and we still do not have any confirmatory evidence to prove that yes, pelvic health has a relation with osteoporosis. So finally, whenever we are assessing any patient who we think are at risk for osteoporosis or could be a potential candidate due to any of the risk factors. So these are certain contextual factors we must keep in mind. So in this box, you can see there are certain genetic factors which I mentioned in my first slide. That certain genetic factors which are, if they are present, they may be prone to osteoporosis. Certain lifestyle factors, we all know about most of it. So if the more number of such risk factors a person has, the more chances the female can have osteoporosis. and medications, diseases. So we have to look at these contextual factors, and the ones which can be modified has to be modified well on time for prevention. And if at all a person is already diagnosed with osteoporosis, we may have to look at the medications, that is the supplements which we have to give, as well as the modifiable risk factors which we can modify. So with this, I hand over the webinar to Anu ma'am to take this session further.